My name is Pratik Chaudhary and I'm a Duke Rheumatology Fellow. Today we'll be discussing a topic which many find quite challenging from a diagnostic and therapeutic standpoint, fibromyalgia. Today we have 4 learning objectives. 1. Learn the clinical features and classification criteria for fibromyalgia. 2. Appreciate the overlap syndromes and differential diagnosis of fibromyalgia. 3. Understand possible pathogenic mechanisms of fibromyalgia. And 4. Learn the pharmacologic and non-pharmacologic treatment mechanisms for fibromyalgia. Fibromyalgia is the most common cause of widespread diffuse pain in the United States, which possibly affects up to 4% of the U.S. population. In 1990, the American College of Rheumatology developed classification criteria to help guide clinicians in the diagnosis of fibromyalgia. These criteria are meant to be a guide and not a definitive diagnostic criteria. In fact, 50% of patients may not fully meet this classification criteria. The ACR 1990 criteria for fibromyalgia includes a history of widespread pain in all 4 quadrants of the body and the axial skeleton, and a physical examination with 11 out of 18 tender points. The figure to the left, obtained from the Mayo Foundation for Medical Education and Research, demonstrates all 18 tender points. A tender point is defined as pain experienced when 4 kilograms of pressure is applied to the skin. In other words, enough pressure to blanch the examiner's nail. The remainder of the physical exam in fibromyalgia is usually unremarkable. Fibromyalgia is challenging because people often have pain at discrete tender points and widespread pain all at the same time. Other associated features of fibromyalgia include fatigue, which is often worse with activity, paresthesias, which often occur in a non-dermathermal pattern, attention and short-term memory deficits, and overlap syndromes, which I will address on the next slide. It is important to note that there is usually no organic explanation for any of these symptoms. This diagram demonstrates how fibromyalgia often occurs alongside other overlapping syndromes, namely regional pain syndromes, chronic fatigue syndrome, psychiatric disorders, and somatoform disorders. Be very careful, as many diseases, some rheumatic, some not, may mimic fibromyalgia. These include mechanical overuse, drugs such as statins, fibrates, and antimalarials, endocrinopathies including hypothyroidism or hyperparathyroidism, Cushing's disease, diabetes, neurologic disorders such as multiple sclerosis or myasthenia gravis, malignancy, infections including HIV, hepatitis C, and Lyme disease, and finally rheumatic diseases including rheumatoid arthritis, systemic lupus erythematosus, Sjogren's syndrome, ankylosing spondylitis, polymyalgia rheumatica, and inflammatory myopathies. Metabolic myopathies, osteomalacia, and a regional pain syndrome also can be seen as mimickers of fibromyalgia. A quarter of patients with lupus, rheumatoid arthritis, or ankylosing spondylitis meet the 1990 ACR criteria for fibromyalgia. Think of fibromyalgia when a patient has persistent complaints of widespread pain despite the apparent control of the inflammatory condition. The regional pain syndromes which often overlap with fibromyalgia include irritable bowel syndrome, interstitial cystitis or painful bladder syndrome, temporomandibular disorders, commonly known as TMJ, idiopathic low back pain, tension headache, and vulvodynia. The psychiatric disorders frequently associated with fibromyalgia include major depressive disorder, obsessive compulsive disorder, bipolar disorder, post-traumatic stress disorder, generalized anxiety disorder, and panic disorder. Chronic fatigue syndrome and somatoform disorders consisting of multiple unexplained symptoms are also considered overlapping syndromes. The pathogenesis of fibromyalgia remains uncertain and somewhat controversial. There is some evidence for a genetic predisposition for fibromyalgia, since first-degree relatives of fibromyalgia patients are 8 times more likely to develop fibromyalgia as well. Also, there has been some investigation into possible polymorphisms in the serotonin 5-HT2A receptor, the serotonin transmitter, the dopamine 4 receptor, and the catecholamine O-methyltransferase enzyme as involved in the pathogenesis of fibromyalgia. Environmental factors such as physical trauma, infections like hepatitis C virus, Epstein-Barr virus, parvovirus, Lyme disease, emotional stress, regional pain conditions, and autoimmune disorders have all been postulated to play a role in fibromyalgia. Other theories focus on abnormalities in pain and sensory processing, where by some yet to be determined mechanism, the threshold for the detection of pain is much lower. Alternatively, augmented central pain processing may play a role as well. We know that elevated substance P has been found in the CSF of fibromyalgia patients. Substance P is a pronoceptive peptide and has been identified as being elevated in the CSF fluid in many chronic pain disorders. A decrease in descending antinociceptive pathways, an alteration in the hypothalamic pituitary pathway, and autonomic dysfunction in addition to psychological and behavioral factors have all been theorized as possible pathogenic mechanisms for fibromyalgia. We now have many treatment modalities for fibromyalgia, some pharmacologic, others non-pharmacologic. First, however, is the importance of labeling the diagnosis. This can be some helpful or detrimental in that many patients will appreciate having a label placed on their disease process, while others will never improve once labeled. Decisions on how to proceed in this regard should be made by a case-by-case basis with clinical judgment prevailing. The importance of patient education and support cannot be overemphasized. Patients need to be reassured that fibromyalgia is a benign, non-progressive condition. There are many support groups available for patients, including the National Fibromyalgia Association, the American Fibromyalgia Syndrome Association, and the Fibromyalgia Alliance of America. Cognitive behavioral therapy, otherwise known as CBT, has been helpful in many chronic diseases and includes relaxation training, activity pacing, and visual imagery techniques. Fibromyalgia patients may find some comfort from these. Aerobic exercises, namely low-impact exercises such as aquatic exercises, walking, stationary cycling, have been shown to be beneficial. As a general rule, encourage patients to start low and go slow, trying to avoid overexertion and injury, which can sometimes make things worse. Complementary therapies such as trigger point injections, myofascial release, and acupuncture may also be beneficial. There are many pharmacological therapies for fibromyalgia, some FDA-approved, others off-label. The cross indicates FDA-approved treatment modalities, while the star indicates off-label use. Tricyclic antidepressants, otherwise known as TCAs, have strong evidence for efficacy in fibromyalgia. Amitriptyline and cyclobenzaprine are examples of this. Antidepressants, namely SSRIs, SNRIs, and SRIs, may be beneficial as well. Fluoxetine is the most extensively studied and beneficial at higher doses and may have a synergistic effect with TCAs. Venlafaxine and duloxetine have also been demonstrated to be helpful. Of all the antidepressants, only duloxetine is FDA approved for the use in fibromyalgia, though many have found success with fluoxetine and venlafaxine for off-label use. Given that fibromyalgia is commercially known as a disease of overactive nerves, anticonvulsants such as pregabalin and gabapentin have demonstrated effectiveness in randomized trials and via anecdotal evidence respectively. Other drugs such as bupropion, nifazodone, and tramadol are also frequently used in fibromyalgia. Finally, the following are some clinical pearls which may be helpful in the management of fibromyalgia. First, consider fibromyalgia only if symptoms are greater than 3 months in duration. If they are less than that, look for another diagnosis. Second, you should always order routine labs such as CBC, chemistries, and ESR and TSH as a means to rule out other disease processes which may explain fibromyalgia symptoms or occur in conjunction with fibromyalgia. As an example, the initial evaluation of a fibromyalgia patient should include the evaluation of thyroid function, because you certainly don't want to miss hypothyroidism, which can explain many of the symptoms of fibromyalgia. In addition, you should only order an ANA or rheumatoid factor if clinically indicated and not on every patient. In terms of treatment, fibromyalgia patients often need a great deal of reassurance. For difficult patients, frequent short-lived appointments are often more beneficial than infrequent, longer-lasting appointments. Finally, remember that it is important to combine pharmacologic with non-pharmacologic therapies for maximum benefit. Combinations of pharmacologic therapies can also be used. This concludes a brief overview of fibromyalgia. For more information, please refer to the accompanying references, which also include the original paper describing the ACR criteria for fibromyalgia. Thank you.